We are going to start our class soon. I'm waiting for participants to join. Some of the participants are online. Can you hear me clearly? Am I audible? We are going to discuss thyroid and antithyroid drugs today. Can you hear me clearly? I have yesterday given one assignment in form of MCQ. Some of the students have already filled. A link is still open today also. Today it will be open till 10 p.m. and it is depending upon the last lecture, which is on corticosteroid. So some MCQ are there and 2 short questions are there. So if you haven't gone through that assignment, please open today and go through the lecture or your textbook and try to answer the correct things. It is not in form of test. It is actually assignment. This is how we are going to learn further. Today I will be giving you another assignment in form of that is depending upon our last lecture that was on oral contraceptive pill. I am going to today give you another assignment. So this is the way how you are going to read as well as to listen to the lectures. Still, yes, I am getting your reply. So I am audible to you clearly. Still, 10 students are there on online. Okay, meanwhile, other students join. Let me ask you some questions of previous class. What is mechanism of action of oral contraceptive pill? What is mechanism of action of oral contraceptive pill? How does oral contraceptive pills act? Reply in chat box. How does oral contraceptive pill acts? 15 students online. Okay, so I am getting reply. Asti says by blocking ovulation. Very nice. Okay, Janvi says by inhibiting ovulation. Yes, very good. Apart from this is the major mechanism of action. You are very right. Blocking release of LH. Again, Janvi says so. Yes, very nice. That is the prominent mechanism of action. By blocking LH, luteinizing hormone secretion, it leads to depression of ovulation. It suppresses ovulation by blocking LH. Okay, another actions, Khyati says by blocking ovulation by mucus in changing mucus in the cervix. Asti says by changing endometrium, Nikita by thinning endometrium. Very nice. So you remember very well. Okay, 19 students are online. Okay, apart from okay, Khyati says by changing endometrium. Now another question. Apart from this oral contraceptive pills, which are other methods of contraception? Which are other methods of contraception apart from oral contraceptive pills? Which are other methods of contraception? I think today my voice will be more clear. Isn't it more clear and more audible? As I am in Rajkot now and my connectivity is very nice today. So yes, Kamali says tubectomy, Kushbu tubectomy, Nikita natural barrier method, Asti patches. What do you mean by 4? Disha says 4 number. Nikita tubectomy and vasectomy, yes. Okay, Rakshava barrier method. Okay, very nice. Still 19 students are there. Please inform to your colleague that our lecture has been started. So to join our class quickly so that we can start. Property, Nancy says property, slow release system, vaginal ring, Asti says. Okay. So please inform to your colleague that our today's class has been started and inform them to join quickly. We are going to start our topic thyroid and antithyroid drugs. Okay, so there are 2 types of drugs we are going to discuss. One one class of the drug that will be acting on the condition of hypothyroidism, and another class of the drug that acts on the condition of hyperthyroidism. So you have learned already in your physiology about hypothyroidism and hyperthyroidism. So in case of the hypothyroidism, the drugs thyroxine itself are to be given, that we are going to see. Thyroxine is hormone, as you know. And in case of hyperthyroidism, the drugs which are helpful to suppress the thyroid hormone secretion, those class of the drug which are going to be given. So you may have heard in your relatives as well as in your nearby relatives that many of them are taking thyroxine, or you may have heard that they are having thyroid disorder. Thyroid ની ખામી છે, thyroid છે, એવું ઘણાને આપણે સાંભળ્યું હશે. So here in this class we are going to see the drugs which are helpful to those patients. So before that, some revision of thyroid physiology which is helpful to you to remember as well as to understand the drug. You may be hearing the cooking cooker. Okay, so thyroid gland secretes two hormone, thyroxine, that is known as tetraiodothyroidine. Just a second. So thyroxine, this is tetraiodothyroidine or T4, and just let me change the color of this, where I can change color. Okay, pointer option, ink color. Okay, yes. So that is known as T4, and triiodothyroidine, it is T3. Our today's topic will be focusing on T4 and T3 and the drugs related to T4 and T3. Secretion ratio of T4 to T3 is 15:1. It means more T4 is secreted than T3. T4 is secreted 15 times more than T3. Okay, so T4 is secreted 15 times more than T3, but T3 is more active. We are again going to see the relation between T4 and T3. So iodine is attached to tyrosine amino residue. No need to remember this. Just understand this T4 and T3. Coupling of this residue produce T4 and T3. So just remember that iodine is important. Iodine is important for synthesis of thyroid hormone. And as you are aware that in case of the hypothyroidism, iodine is recommended. Iodine is recommended. You may be eating iodized salt, that is the fortified salt, iodine fortified salt. So that is why iodine is needed for thyroid hormone. Okay. So that is basic physiology of thyroid gland. T4 and T3 is released by gland in bound and transported form. Just remember this thing: thyroid binding globulin, thyroxine binding globulin is required for the transport of the hormone. Free hormones levels are high, that will be maintained by constant feedback mechanism that we are going to see. Not to remember this physiology. Now, two things: causes of increased thyroxine binding globulin and causes of decreased thyroxine binding globulin. So condition in which there is increased thyroxine binding globulin are pregnancy, estrogen secretion, cirrhosis of the liver, hepatitis, and porphyria. And causes of decreased thyroxine binding globulin are in protein malnutrition, nephrotic syndrome, hepatic failure, androgenic steroid, and high dose glucocorticoid. Just go through this. No need to remember, it will not be helpful in your pharmacology exam. T4 is deiodinated into periphery to form T3. Now this is important to understand. As we have seen that T4 is 15 times more than T3. T4 is 15 times more than T3. But major active hormone is T3, not T4. So what happens in periphery, that in our arms, in our body, what happens that T4, it is converted to T3. T4 is converted to T3. Now remember that T4 is tetraiodothyroidine, means 4 iodine molecules are there. In case of the T4, there are 4 iodine molecules, right? So in case of the T3, In case of the T3, it is triiodothyroid. So it is containing 3 iodine molecule. So to convert T4 to T3, one iodine is to be removed. So that is called as deiodination. That is called as deiodination. Okay, 26, 27 students are online. Please inform that to join. Inform other students who are remaining to join, because it is very interesting topic. You are going to learn more. And there is a system. I do have the system of attendance marking in this software. So if required, I will send attendance also to your class coordinator. So inform them to join. Okay, so we were talking about conversion of T4 to T3. Yes, so this is how 80% of the T3 is produced. Originally, T3 is not secreted from thyroid gland. It is produced by conversion from T4 to T3. So remember this point. Okay. Other metabolite of T4 is RT3. No need to remember this. T3 enters the cell and bind to the group of nuclear receptor and affect wide range of metabolic function. See, in the start of the endocrine system, we have discussed that almost mechanism of action of all the hormone, it is through genetic modulation, through acting on the mRNA. Here it will be acting on the mRNA and altering protein synthesis. So this is common mechanism of action. This is common mechanism of action of all the hormone. They act through RNA or DNA and alter protein synthesis. They alter protein synthesis, and this is how they produce their mechanism of action. Now, these are the steps in biosynthesis of thyroid hormone. First of all, iodine trapping. Iodine is trapped inside the gland. I am shortly going to discuss this because it will be helpful in further pharmacology. Iodine trapping, oxidation of iodide to iodine. First of all, iodine goes inside the thyroid gland. Then this iodide molecule, it is oxidant. It becomes there will be oxidation of iodide to iodine. Then iodide organification. Then formation of T4 and T3 and release of T4 and T3. These are the brief steps which are there in biosynthesis. This is the physiology, and we are not going to see this. So in periphery, thyroxine is deiodinated. As we have discussed previously, that thyroxine is deiodinated to form triiodothyroid in T3, which is 4 times more potent than T4. Again, remember, T4 is 15 times more secreted. T4 is 15 times more secreted than T3, but in periphery, T4 is converted to T3, and T3 is 4 times more potent. T3 is more potent than T4. So this is mechanism of action. Free form of T4 and T3 enter the cell by diffusion. You know that any organ, any drug or any hormone, if they have to produce mechanism of action, they should go inside the cell. So for transport inside the cell, there are different mechanisms: active transport, passive transport, and this is diffusion. This is diffusion or active transport. So whatever the T4 and T3 are released from the gland, thyroid gland, they enter the cell. Suppose they have to produce action in the liver, they enter the cell by diffusion or active transport. And T4 is converted to T3, enter the nucleus and binds to T3 receptor. This leads to increased formation of mRNA. Again, I repeat, T4 is converted to T3, enter the nucleus and binds to T3 receptor. This leads to increased formation of mRNA and subsequent protein synthesis. Again, see, this is the common mechanism acting on mRNA and formation of the protein synthesis. This is the mechanism of action of thyroid hormone. Remember that this will be asked in your exam. If you are asked in your exam thyroxine, then in mechanism of action you have to write down this. Pharmacokinetic, we are not going to see the pharmacokinetic. Okay, this is comparison of T4 to T3. Again, some maybe repetition. As we know, T4 is produced more than T3. T4 is converted to T3 in periphery, that we have already discussed. Now T3 is more potent than T4. Production of T4 is more than T3, but T3 is more potent, more useful, it is having more action than T4. T3 acts faster than T4. T3 enters the cell easily than T4, and T3 binds to receptor in nucleus. Okay, so it is not necessary that whichever hormone is more, T4 is more, which may be helpful more. Okay, so even if T3 is less initially in quantity, but T3 is more helpful. T3 is more helpful. Okay, so write down in chat. Am I audible? Am I audible now? And is PPT visible? And am I audible now? Yeah, आवाज करता नहीं हूँ. Am I audible now? And is PPT visible? Is it visible now? Is it visible now? Am I audible? Okay, is PPT visible clearly? Is PPT visible clearly? Write down PPT is visible. Just yes, sir. I am getting yes, yes, yes. Okay, okay, fine. Okay, okay. So both of these things are clear. Okay, both of these things are clear now. Fine. Okay. But still, please inform other students. Where are other students? 22 students are online. Okay, fine. Thank you. PPT is visible. Okay, we are going to see further regulation of thyroid hormone. So for any hormone regulation, hypothalamus is important part. Hypothalamus secrete releasing hormone. So hypothalamus here secrete in case of the thyrotropin releasing hormone. Hypothalamus secrete thyrotropin releasing hormone. This thyrotropin releasing hormone stimulates synthesis and release of the thyroid stimulating hormone TSH. First remember TRH. TRH is released from hypothalamus, and TSH is released from anterior pituitary gland. So first hypothalamus with secrete TRH, then it acts on the pituitary with secrete TSH, that is thyroid stimulating hormone, and this TSH then stimulate the thyroid gland for uptake of iodine synthesis and release of T4 and T3. Again, we are going to see this with the help of the figure. So again, you can see that this is hypothalamus. This is hypothalamus with secrete TRH, Then TRH act on the anterior pituitary. This is anterior pituitary with secrete TSH. You can see that secrete TSH, and this TSH act on the thyroid gland to release T4 and T3. So this is known as hypothalamo-pituitary thyroid axis. Hypothalamo-pituitary thyroid axis. Okay. Now hypothyroidism. Symptoms of hypothyroidism. Which include cold intolerance, which includes some students are not clearly audible. Cold intolerance, dyspnea. So patient cannot tolerate cold. In case of the hyperthyroidism, there will be heat intolerance. Here there is cold intolerance. Then dyspnea, that is difficulty in breathing, anorexia, constipation. So here in hypothyroidism there is constipation. Okay, in hyperthyroidism there will be diarrhea. So here is GIT system becomes sluggish. So patient is not able to pass stool and there is constipation. In case of the hyperthyroidism, there will be we are going to see that there will be diarrhea because GIT activity is more. Then menorrhagia, amenorrhea, arthralgia, myalgia, menorrhagia or amenorrhea, depending upon the patient. In some patient there will be menorrhagia, in some patient there will be amenorrhea. So it is not fixed which will happen. Arthralgia, myalgia, fatigue, depression, irritability, decreased alteration in memory, and paresthesia. So these are the symptoms of hypothyroidism. Meanwhile, let me check. Write down relation of T4 and T3 in chat box. What is relation of T4 and T3? Write down that in chat box. Read this hypothyroidism also. Symptoms of hypothyroidism. I will ask later on symptoms. Now write down relation of T4 and T3 in chat box. Relation of T4 and T3 in chat box. Meanwhile, I am repeating hypothyroidism symptoms: cold intolerance. In case of the hyperthyroidism, there is a heat intolerance, dyspnea, anorexia, constipation, menorrhagia or amenorrhea, arthralgia, myalgia, fatigue, depression, irritability, decreased alteration in memory, and paresthesia. So these are the symptoms of hypothyroidism. Write down what are the relation of T4 and T3. We have discussed which is more, T4 or T3, which is more potent. Okay, now I'm getting replies. T4 converts to T3. Yes, Nikita, T4 is 5 times more than potent than T3 5 times more potent than T4. Kamali, T4 5 times more, 15 times more than T3 in our body. Yes, very nice. Okay, fine. Okay, so hypothyroidism again, hair thinning, you can see depression, schizophrenia, irritability, big tongue. So in hypothyroidism, body will become large. In hyperthyroidism, body will be small. Remember like that. So in hypothyroidism, there will be obesity. There will be constipation. There will be myxedema, cold skin, cold intolerance, weak heartbeat, slowing of the mind and body. Okay, so that is decreased sensation of the mental sensation. Signs of hypothyroidism. You can see that visible hypothyroidism: dry, yellow skin, weight gain. Okay, so in hypothyroidism, there will be obesity. In 41% cases of the hypothyroidism, there will be weight gain. Thinning, coarse hair, thin and coarse hair, myxedema signs, that is mucopolysaccharide deposition in tissue, puffy eyelids. You can see the eyelids. Here in first photograph, this eyelids, puffy eyelids, hoarseness of the voice. Okay, so here what I have told, that body becomes big. In general, you remember the big tongue, puffy eyelid, visible enlargement of this thyroid gland, and there will be swelling over the neck region, obesity, and because of this thickening all over the body, inside as well as outside, there will be hoarseness of the voice. Because of the thickening over the hand, there will be carpal tunnel syndrome. You know about very well carpal tunnel syndrome. Because of the thickening, there will be compression of the median nerve, and so that there is carpal tunnel syndrome. There is anemia, dependent edema. So these are the symptoms of hypothyroidism. Okay, so causes of, there are two types of hypothyroidism: primary hypothyroidism and secondary hypothyroidism. So causes of hypothyroidism, we are talking about why there is less production of the thyroid hormone. Autoimmune disease is the most common cause of hypothyroidism because of immunity against thyroid gland itself. Because of the immunity against thyroid gland itself, there is hypothyroidism. Okay. Post-surgical thyroidectomy. In case if thyroid gland removal is there, then there is no production of thyroid hormone. Thyroidectomy is thyroid gland removal. External radiation leads to decrease in thyroid hormone secretion. Iodine I-131, that is radiothyroidine, which is used for treatment of the hyperthyroidism. If you use iodine for treatment of hypothyroidism, then this iodine will lead to hypothyroidism. That is the adverse effect of radioactive iodine. Severe prolonged iodine deficiency, autoimmune medications such as lithium, inherited enzymatic defect, true idiopathic, these are causes of primary hypothyroidism. Some other causes, hypothyroidism and myxedema. These are the symptoms: hypotension, bradycardia, pericardial diffusion, low voltage ECG, prolonged QT interval, inverted or flattened QT wave. So for that, thyroid function test is to be done. Okay. Now write down in chat box what are the symptoms and signs of hypothyroidism. What are the symptoms and signs of hypothyroidism? Write down in chat box. Write down in chat box what are symptoms and signs of hypothyroidism. Mention in chat box. Then we will move further on thyroid function test, as well as we are going to see the treatment of hypothyroidism. What are the symptoms and signs of hypothyroidism that we have discussed? Write down in chat box. And as you know that I have also given today, yesterday itself, MCQ assignment as well as 2 short questions on corticosteroid. So fill it also today. It's based on our lecture. NC says menorrhagia or hemorrhagia, then weight gain, yes, carpal tunnel syndrome, constipation, intolerance to cold, bradycardia, hoarseness of voice, yellow skin, hair, thinning. Okay, very nice. Okay, fine. So we are going to see thyroid function test. In case of disease, whether it is nothing but estimation of T4 and T3. Mainly T4, free T4, then T3, okay, and serum TSH. So serum T4, serum T3, and serum TSH. So as you know that in case of the hypothyroidism, T4 and T3 level will go downward. So there is decrease in T4 and T3. So what happens to TSH? TSH level will rise. It is opposite. As the T4 and T3 decreases, there will be more signaling from the pituitary gland to release this T4 and T3 to balance. That is, we have studied about hypothalamus pituitary thyroid axis. So as T4 T3 goes downward, so serum TSH level will increase. What happens in case of the hyperthyroidism? T4 and T3 level rise, so that TSH level decreases. Okay. Then TRS stimulation test. No need to remember this. Just remember T4, T3 estimation and serum TSH. Now for hypothyroidism. First is levothyroxine, T4. Remember this name, levothyroxine. As you know that thyroxine is the hormone, endogenous hormone which is synthesized in our body. Now here thyroxine preparation, it is prepared in form of the drug levothyroxine. So this is the preparation of choice for thyroid replacement. Thyroid replacement means here we are not replacing gland, we are replacing hormone. Thyroid hormone is not enough in our body. It is not produced enough in our body, so we are replacing in form of drug. So it is thyroid replacement therapy. So remember that hormone replacement therapy is there. We are giving hormones in form of the drugs. That is always called hormone replacement therapy. Like in case of the estrogen, progesterone also. So it is stable and it has a long half-life. It is administered once daily. Remember this, levothyroxine, it is administered once daily. Oral preparations are available, oral drugs are available, and these drugs are not available not in form of that strips. It is available in form of bottle. In umber color bottle, these drugs are thyroxine is available. It is to be protected from the sunlight. Okay. And it is available in this dosage 0.025 to 0.3 milligram tablet. For parenteral use, for injectable use, 200 to 500 microgram, 100 microgram per ml is available as injection. But most commonly, oral preparations are to be given in thyroid replacement therapy. Another drug is liothyronine, that is T3. This was T4 and this is T3. It is more potent, 3 to 4 times more potent, rapid acting than levothyroxine, but has short half-life, 24-hour only. 24-hour half-life is there. Here you can see that half-life is 7 days. Half-life is 7 days. Here it is 24 hours only compared to this levo. So it is not recommended for routine replacement therapy, not recommended. This levothyroxine T3 is not recommended. It requires multiple dosing in a day. It is to be avoided in cardiac patient also. Oral preparation 5 to 50 microgram, and for parenteral use 10 microgram per ml. So for routine therapy, thyroxine, levothyroxine, that is the drug of choice. Preparation of the choice for thyroid hormone preparation. Now, treatment of myxedema, coma. That is one form of the hypothyroidism in which there can be myxedema. These are the points. First of all, O2 intubation may be necessary in case of the respiratory failure. Ventilation, you may be hearing about ventilation nowadays because of the corona infection. So that is here in myxedema, coma also. Ventilation is to be given. Rapid blood glucose check. Okay, so serum glucose should be given, or if required, IV pint of glucose is to be given. Hydrocortisone 100 to 500. Hydrocortisone 100 to 250 milligram IV. Cautious slow rewarming, warm O2 scalp, and then thyroxine hormone at 25 microgram of the T3 also on careful IV rehydration. So this was all about hypothyroidism. Now we are going to see about hyperthyroidism. So these are known as disorders of thyroid hormone excess, means hyperthyroidism. So most commonly here in hyperthyroidism is thyrotoxicosis. There are two terms, hyperthyroidism and thyrotoxicosis. So thyrotoxicosis is the term for all disorder with increased level of circulating thyroid, or in which thyroid test distinguish between hyperthyroidism from other form of the thyrotoxicosis. Okay, so there is a very small thin line between hyperthyroidism and thyrotoxicosis. If you don't remember, it will be okay. Just remember that increased thyroid hormone secretion occurs in both of these. Then, so thyrotoxicosis, there are causes. Most commonly Graves' disease, pituitary tumor secreting excess, pituitary tumor which secretes excess TSH. As you know that thyroid stimulating hormone is secreted from pituitary. I'm explaining you second point. Thyroid stimulating hormone is secreted from anterior pituitary. If there is tumor of the pituitary gland, so there will be excess secretion of the thyroid stimulating hormone, which will lead to excess secretion of the thyroid hormone from thyroid gland. Okay, so that is pituitary tumor which is secreting excess TSH, which lead to thyrotoxicosis. Pituitary insensitive to feedback. Okay, now I'm explaining this. See what happens that whenever there is increased level of T4 and T3, it leads to negative feedback inhibition over the pituitary. Negative feedback, that there is enough T4 and T3 in body. Now pituitary doesn't need to secrete TSH. So that is negative feedback mechanism. That is normal physiology. But what happens that pituitary becomes insensitive to negative feedback. It keeps secreting TSH. It keeps secreting, and that is leading to thyrotoxicosis. Then H-mole, hydatidiform mole. You may have learned this in gynecology. Choriocarcinoma, testis embryonal carcinoma, toxic multinodular goiter, toxic unilocular goiter. This you will be learning in surgery. Drugs inducing hyperthyroidism. So there are some drugs which may also lead to hyperthyroidism, like iodine. Iodine we are taking is iodine is a iodized salt. If there is excess iodized salt in our diet, it will lead to hyperthyroidism. Some drugs like used in psychology, the psychopharmacology, that is used for bipolar manic depressive illness, lithium. It also leads to thyrotoxicosis. Okay, 30 students are online. We'll be talking for 20 minutes. Okay, features of Graves' disease, toxic nodular goiter. You can see that the eyes are staring look. So most common cause of hyperthyroidism is Graves' disease. It is caused by thyroid stimulating immunoglobulin. I will be discussing the features. Most often have long-standing goiter. We will skip this. Okay, symptoms of thyrotoxicosis. Remember these symptoms. I will ask later on. Nervousness, restlessness, shortened attention span, emotional liability, difficulty in sleeping, increased appetite, weight loss. So remember, compare it with hypothyroidism. In hypothyroidism, there is obesity. Here in hyperthyrotoxicosis, there is weight loss. Heat intolerance. What happens in case of the hypothyroidism? There is cold intolerance. Then fever, diaphoresis, weakness, menstrual irregularities. It is also there in case of the hypothyroidism. We have seen that menorrhagia and amenorrhea. Now, signs of thyrotoxicosis. These were symptoms. Sinus tachycardia. Here, heart rate becomes increased. Sinus tachycardia, atrial fibrillation. So that is another form of the arrhythmia. Atrial rate is increased, say for 200, 300. So it is atrial fibrillation. Tremor. If you how do you examine this tremor? In many patients, there may not be tremor. They may not be complaining of the tremor, but you can ask them to stare. So whenever you keep the hands your straight, it may be tremoring like this. It may be tremoring. So that is one sign of hyperthyroidism. That is how hyperthyroidism is examined. So tremor, then hyperreflexia, muscle wasting. In case of the thyrotoxic, muscle wasting, warm, erythematous, moist skin, alopecia. So one of the reason of alopecia may be thyrotoxicosis. Nail becomes friable, separation, nail becomes separate from their bed. Hyperventilation, eyelid retraction. Yes. So that is why you can see that eyelids here in this upper eyelid and lower eyelid, they become retracted. Upper eyelid goes upward and lower eyelid goes lower, downward, because there is pushing of the eyeball externally. So that is why there is eyelid retraction. Okay. So lead leg. Yes, lead leg means upper eyelid don't fully cover. Upper eyelid doesn't fully cover the whole eyeball. Whenever we are sleeping, yes, you know that our upper eyelid fully covers our eyeball. But here lead leg means upper eyelid doesn't fully cover our eyeball, and eyeball is visible during sleep. Persistent staring look. You can see in this photograph, staring look. એક સાથે તાકીને જોયા કરે એવું staring look. Hyperactive bowel sounds. So what happens in case of the hypothyroidism? There is constipation. Here bowel become hyperactive, and because only hyperactive bowel sound to someone, don't say that he is having thyrotoxicosis. We need to examine other signs also. With Graves, there may be exophthalmos. So this is exophthalmos. Exophthalmos means eyeball comes outward. That is exophthalmos. Tender, enlarged thyroid, and pretibial myxedema. These are the signs of thyrotoxicosis. So I am giving you 2 minutes. Remember this same symptoms of thyrotoxicosis and signs of thyrotoxicosis, and then write down. So first of all, I will be focusing these 2 slides over you. So read these symptoms of thyrotoxicosis. Remember it. Try to remember some of the symptoms. Try to remember the signs. I am reading again. Nervousness, restlessness, shorten attention span, increase appetite, emotional liability, then this weight loss, heat intolerance, diaphoresis, weakness, menstrual irregularities. These are the symptoms. And signs: sinus tachycardia, atrial fibrillation, so heart, tremor, hyperreflexia, muscle wasting, warm erythematous moist skin, alopecia, nail friability, hyperventilation, eyelid retraction, lead leg, persistent stare look, hyperactive vowel sound. There may be exophthalmos, tender or enlarged thyroid, and pretibial myxedema. Okay. Now we are going to see the antithyroid drugs. So antithyroid drugs are thioamide. So I will be tick mark these names. Almost I think all 2-3 drugs are only there. So you have to remember all of this. So first class is thioamide, which contains methimazole or carbimazole or propylthiouracil. Remember all these 3 names in thioamide: methimazole, carbimazole, and propylthiouracil. Then radioactive iodine. Second is radioactive iodine. There is I-131 iodine. Iodine, that is aqueous potassium iodide solution. Then iodinated contrast media. This is not routinely used, so you cannot remember this. So you remember again, I repeat, thioamide, which contains this methimazole, carbimazole, or propylthiouracil, radioactive iodine, and iodide. So mechanism: agent which interfere production. So here, as you know that there is increased thyroid hormone secretion. So we need to give this drug with decreased thyroid hormone secretion, or which decrease the level of the thyroid hormone by any mechanism. So here mechanism. So this can be the agent which interfere production of the thyroid hormone, decrease the production of the thyroid hormone. The agent which modify tissue response to the thyroid hormone, even if there is more thyroid hormone production, response of the tissue to thyroid hormone will be decreased. Okay, we want to decrease thyroid hormone secretion, or we want to decrease the tissue response. Then there can be the mechanism glandular destruction, like this iodine that can destruct, or this radiation that can destruct the thyroid gland itself with radiation or with surgery. So radiation and surgery, these are another option to destruct the thyroid gland. So first of all, thioamide, methimazole, carbimazole, and propylthiouracil. So methimazole is 10 times more active than propylthiouracil. They act by inhibiting. Remember this mechanism of action. This is mechanism of action. Inhibit thyroid peroxidase enzyme. So this enzyme is important in thyroid hormone synthesis. So by inhibiting thyroid peroxidase enzyme, remember the mechanism of action of thioamide, methimazole, carbimazole, propylthiouracil, all act by inhibiting thyroid peroxidase enzyme, so that they will block this iodine organification, they block coupling of the iodothyroidine, and inhibit peripheral deiodination of T4 to T3. So there are multiple action. Main action is inhibition of thyroid peroxidase enzyme. Then this is also important. Peripheral conversion of T4 to T3 is also inhibited. Onset of the drug is slow, requiring 3 to 4 weeks. It is not so that like diclofenac or this brufen, that if you give drug today, action will start today. It will require 3 to 4 weeks for initiating the action of this drug. So it is long-term therapy. In many diseases there is always long-term therapy. Hypertension, diabetes, I think in both of the diseases there is lifelong therapy. Here in thyroid also there is lifelong therapy. So these are in case of the psychopharmacology. In case of the mental disorder also, at least 3 years of the therapy is needed. So now write down what are the symptoms and signs of hyperthyroidism in chat box. Write down symptoms and signs of hyperthyroidism. I will be today giving you the assignment of oral contraceptive pills. We have learned So in form of this MCQ, yes, I am getting reply. I think you have already typed, and whenever I am asking, you are sending. Smart. Nervousness, weight loss, nervousness, fever, weight loss, increased appetite. I am getting fast reply. You have already typed. You become smart. All of you have become smart. Weight loss, weakness, eyelid retraction, heat intolerance, fever. So many students have replied. Okay, very nice. Write down the names of the drug which we have recently discussed. Names of the drug, antithyroid drug, menstrual disturbance, excessive sweating, tremor. Write down the name of antithyroid drug which we have discussed recently. Nail friability, yes. Menstrual irregulation. Names of the antithyroid drug, yes. Methimazole, then thioamide, methimazole, carbimazole. Okay, very nice. Methimazole, carbimazole. You are enjoying this live lecture, I think. Carbimazole. Apart from, yes, propylthiouracil. Then one, this is thioamide. This is thioamide. Apart from thioamide, so you are enjoying. I am getting reply, yes, sir. Propylthiouracil. Apart from this, yes, I-131, that is radioactive iodine. Okay, now we are moving forward. We will be discussing for 10 minutes. No need to discuss this. Okay, now adverse effect of thioamide. It occurs in 3 to 12% of the treated patient. What adverse effect? Maculopapular rash and fever. We are discussing adverse effect of thyroid. Maculopapular rash, macules and papules, you know, fever, urticarial rash. So rash is common side effect. Vasculitis, arthralgia, cholestatic jaundice, lymphadenopathy, and hypothyroidism. So again, I repeat: rash. These are both type: maculopapular and urticarial rash, vasculitis, arthralgia, cholestatic jaundice, lymphadenopathy, and hypophosphatemia. Some of the students, I said that you are enjoying this lecture. So some of the students said, yes, okay, I'm happy that you are enjoying. But you know that it is very difficult to speak in front of the persons. There are no persons in front of me. There are no persons. I'm facing camera. I'm talking to camera. I am feeling like that. I have to watch inside the lens and I am talking. So without presence of any person, it is difficult to interact for me. But you are enjoying, so I am also enjoying. Okay, so most dangerous complication is agranulocytosis. Agranulocytosis. This may be fatal also. Iodide, Lugol's iodine, well and rapidly absorbed from intestine, rapidly taken by thyroid gland and concentrated there. We have talked about thioamide. Okay, now another topic, that is Lugol's iodine. Rapidly taken by thyroid gland and concentrated there. Moderate increase leads to hormone secretion, but substantial increase inhibits hormone release. Remember this is the mechanism of action. See, this is the dual mechanism of action. It is very interesting to understand. Moderate in amount, if we give iodide moderate in amount, it will increase thyroid hormone secretion. So it is helpful in hypothyroidism. But if we give substantial excessive iodine, excessive iodides, so it will decrease this thyroid hormone secretion. So it is helpful in case of the hyperthyroidism also. Okay, so that is having dual mechanism. Iodide stores in thyroid delay response to thioamide. So whenever we give thioamide and iodide together, the response of the thioamide will be decreased. So they should be initiated after the onset of the thioamide therapy. So iodide should not be used as the single therapy. It can be given in combination with the thioamide. It should not be used in pregnancy. May produce iodism, that is excessive iodine. We are giving iodides, so it will be leading to iodism, causing acneiform rash, swelling of the salivary gland, mucous membrane ulceration, metallic taste, and rarely anaphylaxis. But most commonly used drugs are thioamide, methimazole, carbimazole, propylthiouracil. This is not commonly used. Radioactive iodine I-131, that is also administered orally. Remember this is radioactive iodine is oral preparation. It is rapidly absorbed, concentrated in thyroid gland and stored in follicle. In thyroid gland, there are thyroid follicle. It has half-life of 8 days. Okay, and it emits gamma radiation. As you know that it is I-131 isotope, so that is radioactive. So it emits gamma radiation and beta particle. The beta particle get accumulated in the gland and destroyed the gland parenchyma. So that is how. That is very simple mechanism to understand. Radioactive iodine, it produces gamma rays, it produces beta particle, and this beta particle destroyed thyroid follicle. It destroyed thyroid parenchyma. Okay, so thyroid hormone secretion will decrease. It is easy to administer, effective, and painless. Very easy. Orally, it is to be administered orally. Effective, painless, and less expensive. It causes destruction of the parenchyma, necrosis, and follicular disruption. So this is the mechanism of action of radioactive iodine: destruction of thyroid parenchyma, necrosis of the thyroid, and follicular disruption. So therapeutic effect is because of emission of the beta rays, beta particle or beta rays, both are similar. Patient with age above 40 years only can be treated with this. It causes placenta excreted in breast milk, and it may cause genetic damage. So why? Because patient in above 40 years should be used because it causes genetic damage, leukemia, neoplasia. It may be carcinogenic also. Iodine contrast media. Just 2-3 slides are there, so let me finish. 2-3 slides only are there, so I will finish it. Iodine contrast media, iodinated contrast media, oral oral iodoped. Just a second. And IV used, no need to remember this, we will skip this. Drugs causing euthyroid hyperthyroidism, no need to remember this. Okay, Thyroid Storm, that is hyperthyroid crisis, that is exaggerated thyrotoxicosis. Thyrotoxicosis is exaggerated, then it is called Thyroid Storm, like common storm. Whenever there is fast wind and it becomes excessively fast, it is known as storm. So that is hyperthyroid crisis. It may be life-threatening, sudden onset thyroid hyperactivity. Like sudden onset of the high speed of the wind is, we call it the storm. So here also sudden onset of the hyperthyroidism is also called thyroid storm. Here it may become life-threatening. No need to go into the detail of this. You may learn in surgery. So causes of this are thyroiditis. Most common is secondary to Graves' disease, toxic multinodular goiter, malignancy. Feature of this storm are high fever, abnormal mental status, agitation, confusion, psychosis, marked tachycardia, vomiting, jaundice, and Graves' disease. Treatment is high flow oxygen, rapid cooling, ice pack, IV fluid, propranolol. So this topic is more important in surgery. And treatment is diltiazem, hydrocortisone, diuretic, sodium iodide. Okay, so thank you. Thank you for the now. Thank you for the now. Any questions? Any questions? Remember that I have given already to you about MCQ assignment as well as 2 short questions of corticosteroid. So go through it and give the correct answer. Go through the lecture, go through the textbooks, and give the correct answer. It is not test. Okay. I am today going to give you MCQ on this oral contraceptive, as well as if time permits, I will be giving you another. I will include also other topic. So that link will be also open till I will decide later on. But the link for this corticosteroid, it is open till 10 p.m. today. So go through it. Okay, thank you very much. Any feedback? Is there any feedback? Any question? Any question or any feedback on this session? Any questions or any feedback for this session? We have discussed this hypothyroidism and hyperthyroidism. So the drugs on hypothyroidism, iodine, iodized salt, or I mean to say drug is thyroxine. Iodized salt is used for preventive purpose. Drugs are carbimazole, methimazole, propylthiouracil, radioactive iodine. Okay, so we are going to end this. Thank you very much to all of you. Okay, thank you.